Good morning, everyone. As clinicians, we are constantly surrounded by high-tech monitors, advanced imaging, and complex lab panels. But today, we are going to strip all of that away and focus on one of the most fundamental, yet frequently mismeasured vital signs in clinical medicine, the respiratory rate and its patterns. We often treat the respiratory rate as just a number to quickly write down on a chart. But over the next few minutes, I want to show you how a patient's breathing pattern is actually a real-time window into their central nervous system, their metabolic status, and their cardiovascular stability. Let's dive in. Let us begin with respiratory rate. Respiratory rate is the number of breaths taken per minute and is often called the forgotten vital sign. Studies have shown that abnormalities in the respiratory rate may appear earlier than changes in pulse, blood pressure, or oxygen saturation. Therefore, careful assessment of respiratory rate is an essential component of bedside examination. Let's start with a reality check. How do we actually measure respiratory rate? If you ask a patient to breathe normally while I count, they instantly change their breathing pattern. The secret to an accurate measurement is clinical stealth. You want to place one hand over the patient's upper abdomen to observe the physical rise and fall. At the exact same time, use your other hand to palpate their radial pulse. This tricks the patient into thinking you are just checking their heart rate, allowing them to breathe naturally. Count those respirations for a full 60 seconds. As you can see in this image, the doctor has placed his one hand over the radial artery at the wrist while placing his other hand over the upper abdomen. Observe the rise and fall of the abdomen. During inspiration, the abdomen rises, while during expiration, the abdomen falls. Count respirations for 1 minute. Remember, our normal resting rate is 16 to 20 breaths per minute, maintaining a tight 4:1 ratio with the pulse rate. If that ratio is disrupted, something is fundamentally wrong. While we look at the clinical deviations, we split the tracks into two primary directions: tachypnea and bradypnea. Tachypnea is defined as a respiratory rate climbing past 20 breaths per minute. It's the body screaming for oxygen or scrambling to blow off excess acid. On the flip side, we have bradypnea dropping below 10 to 12 breaths per minute. Bradypnea is a massive red flag that the respiratory drive itself is shutting down, whether due to toxins, metabolic failure, or structural neurological damage. Let's break down what drives each of these. Let's unpack tachypnea. While it can be perfectly physiological, like during strenuous exercise or an acute panic attack, in the medicine wards, it is usually a compensatory survival mechanism. Look at the pathological drivers. In pulmonary conditions like emphysema, pneumonia, or a massive pulmonary embolism, tachypnea compensates for localized hypoxia. Metabolically, it's driven by metabolic acidosis. Cardiovascularly, we see it in acute heart failure and severe anemia where tissue oxygen delivery is compromised. It also crops up in systemic conditions like hyperthyroidism or restrictive chest wall diseases. The golden rule here: do not just try to slow the breathing down. Find the underlying cause, treat it, and the tachypnea will resolve on its own. Now let's look at the opposite extreme, bradypnea. When the respiratory rate plummets, your diagnostic mind should immediately go to three core areas. First, CNS depressants like opioids, benzodiazepines, barbiturates, and severe alcohol intoxication directly suppresses the brainstem's respiratory center. Second, metabolic shutdown, such as profound uremia or severe hypothyroidism. And third, critical structural or physical insults, namely raised intracranial pressure, think Cushing's triad, and severe hypothermia. Never take bradypnea lightly. Severe cases quickly spiral into severe hypoventilation, profound hypoxemia, and acute respiratory failure. Breathing involves coordinated action of several muscle groups. The diaphragm is the principal muscle of respiration and contributes nearly 70% of inspiratory effort. Accessory muscles become active when respiratory demand increases. To understand abnormal breathing patterns, we must first master the mechanics of normal breathing, starting with inspiration. Under normal conditions, inspiration is an active process driven by your primary powerhouses, the diaphragm and the external intercostals. The diaphragm contracts and moves downward, instantly expanding thoracic volume. But when a patient hits respiratory distress, they have to recruit their accessory muscles. If you see a patient actively using their sternocleidomastoid, their scalenes, serratus anterior, pectoralis, or trapezius, they are burning massive amounts of energy just to pull air in. This is a clear warning sign of impending respiratory exhaustion. Now, let's flip the coin over to expiration. In a healthy individual sitting at rest, normal expiration is entirely passive. It relies completely on the natural elastic recoil of the lungs and the chest wall to expel air. No muscular effort required. However, when a patient experiences severe airway obstruction or needs to forcefully clear their airways, expiration shifts into an active high-effort process. This forces the recruitment of the internal intercostals to depress the ribs, alongside the abdominal muscles quadratus lumborum and latissimus dorsi to forcibly drive the diaphragm upward. If you see a patient actively using their abdominal muscles to push air out, you are looking at a patient working dangerously hard to breathe. When you approach the bedside to evaluate respiration, you need a systemic method. Keep the patient comfortable, stand at the bedside, and observe whether the chest or the abdomen moves more. This brings us to a key physiological distinction. Abdominothoracic respiration is where abdominal movement predominates, typically seen in healthy males, due to well-developed abdominal wall dynamics. Conversely, thoraco-abdominal respiration features prominent thoracic movement, which is classically seen in healthy females due to intercostal muscle utilization. Recognizing these baselines is critical because a sudden shift in these patterns points directly to underlying pathology. In this image, you can see, as we have already discussed, how to examine the type of respiration. One hand is placed on the chest and the other on the abdomen. The dominant movement determines whether respiration is abdominal or thoracic. Let's look at what happens when these patterns completely split apart into pathological extremes. First, purely thoracic respiration, where abdominal movement is entirely absent. So why would a patient freeze their abdomen? Because moving it causes excruciating pain or is physically restricted. Think acute peritonitis, third trimester pregnancy, massive ascites, or a giant ovarian cyst. Second, purely abdominal respiration, where the chest wall remains completely still. This happens when moving the chest hurts, such as severe pleuritic chest pain or a defective chest wall, or when the thoracic machinery is paralyzed, as we see in respiratory muscle paralysis and neuromuscular disorders. Now, let's transition into the core of advanced clinical physical diagnosis, abnormal breathing patterns. When you identify an abnormal pattern, your first step is to categorize it into one of the two tracks. Is it regular or is it irregular? Regular abnormal patterns follow a predictable repeating cycle. This group includes Cheyne-Stokes, Kusumols, and pursed lip breathing. Irregular patterns, on the other hand, are chaotic, unpredictable, and highly dangerous, including Biot's, ataxic, and apneustic breathing. Let's break each of these down so you can identify them instantly at the bedside. First up is Cheyne-Stokes respiration. This is a beautiful, albeit concerning, cyclical pattern of waxing and waning. It begins with a period of absolute apnea. Then, shallow breaths emerge, gradually increasing in both depth and rate, the crescendo phase, until they hit a peak hyperapnea. Immediately after, the depth and rate begin to decline, the decrescendo phase, fading right back into a period of apnea before the entire cycle repeats. So here the question is, what drives this? It is a delayed feedback loop between the lung and the brainstem's chemoreceptors. While you can see it in patients with raised ICP or brainstem lesions, the most common clinical culprit you will encounter on the wards is severe left ventricular failure. Next, we have Kussmaul's breathing. Unlike Cheyne-Stokes, there is absolutely no waxing, waning, or apnea here. Kussmaul's is characterized by rapid, remarkably deep and labored breathing. It is a relentless, sustained hyperventilation. So why does this happen? This is the respiratory system acting as a heroic metabolic buffer. When a patient develops severe metabolic acidosis, the body kicks into compensatory hyperventilation to blow off as much carbon dioxide as possible, trying to drive the systemic pH back up. If you see a patient with deep, rapid, regular respirations, you are looking at severe metabolic distress, classically DKA, or advanced renal failure. See this slide and imagine a young diabetic patient arriving in the emergency room. The patient is breathing rapidly, deeply, and laboriously. This is Kussmaul's breathing. It is the body's attempt to blow off carbon dioxide and compensate for metabolic acidosis. Moving into our irregular patterns, let's look at Biot's respiration. Biot's is characterized by clusters of rapid, regular breaths of equal depth, followed by an abrupt, completely unpredictable stop into apnea. Think of it as a series of normal depth breaths that suddenly hit a wall. This pattern points directly to neurological dysfunction, specifically lesions in the pons or medulla that disrupt the automated respiratory centers. If you see Biot's respiration at the bedside, your top clinical suspicion should be meningitis or severe encephalitis. It is an unstable, ominous pattern that demands immediate neurological and airway evaluation. In Biot's breathing, you need to understand a very important point. It contains groups of breath of equal depth interrupted suddenly by apnea. The rhythm is regular and unpredictable. The point I am trying to make you understand is that it contains regular breaths of equal depth followed by irregular periods of apnea. The apnea periods are not regular, they are irregular, but the breaths are of equal depth and regular. If Biot's respiration is a disrupted pattern, ataxic respiration is absolute chaos. It features completely irregular breathing with zero predictable rhythm and highly variable respiratory depths. There is no pattern to follow here. This chaos occurs due to complete structural or chemical dysfunction of the medullary respiratory centers, destroying their ability to regulate the rhythm of breathing. You will see this in advanced brainstem lesions, severe cerebellar disasters, metabolic encephalopathies, or profound drug overdoses such as acute opiate toxicity. Ataxic respiration carries a very poor prognostic significance and is often a final step before complete respiratory arrest. Now let's examine apneustic respiration, a pattern dominated by a profound inspiratory cramp. Here, you see a prolonged, sustained inspiration where the patient draws in air and holds it, followed by a brief, rapid, or almost absent expiration. Mechanically, this happens because A lesion has knocked out the off switch for inspiration in the lower pons. Without that off switch, the inspiratory drive runs unchecked. The common causes are severe pontine insults, such as an acute pontine stroke, severe head trauma, or advanced tumors. It indicates profound central nervous system dysfunction and requires immediate urgent intervention. Let's look at a fascinating compensatory pattern that you will see daily on the medical wards. Pursed lip breathing. Patients involuntarily do this by breathing in through their nose and exhaling slowly through their tightly puckered lips, as if they are trying to whistle or blow out a candle. So why do they do this? By exhaling against tightly closed lips, they intentionally create resistance to expiratory airflow. This builds back pressure within the airways, creating a physiological phenomenon known as autopy, positive end expiratory pressure. This internal pressure holds the small airways open, prevents early airway and alveolar collapse, and improves overall oxygenation. This is the classic hallmark of a patient dealing with COPD. Most of us have seen COPD patients breathe through tightly pursed lips. Now you know this is not merely a habit, it is a physiologic adaptation. As we near the end, let's look at how the physical location of an airway obstruction dictates the exact breathing pattern you see at the bedside. If a patient has an upper airway obstruction, think foreign body, epiglottitis, or laryngeal edema. The main challenge is pulling air past that narrow proximal bottleneck. Consequently, the respiratory pattern shows a prolonged inspiration, often accompanied by stridor. Conversely, if the patient has a lower airway obstruction, like acute asthma or a COPD exacerbation, air enters easily but gets trapped in the distal airways. The challenge here is squeezing the trapped air out, leading to a markedly prolonged expiration accompanied by wheezing. Just by listening to the ratio of inspiration to expiration, you can immediately narrow down the anatomic site of obstruction. To tie everything we have discussed together, let's look at this master summary matrix. This is a clinical cheat sheet. Look at how clearly the waveforms reflect the underlying pathology. Notice the smooth cyclical rise and fall of chain strokes in heart failure compared to the sharp erratic breaks of Biot's in meningitis and the deep relentless waves of Kussmaul's in DKA. When you are out on the wards, use this visual framework to guide your assessments. Recognize this pattern, identify the cause, and deliver the targeted care your patient needs. Let's close with some high-yield pearls that every doctor should know by heart. Normal respiratory rate is 16 to 20 breaths per minute. The diaphragm is the most vital muscle of respiration. Left ventricular failure is the number one cause of Cheyne-Stokes respiration. Kussmaul's breathing is the classic hallmark of DKA. Biot's breathing points directly to meningitis. An apneustic pattern tells you that there is a lesion in the pons. Pursed lip breathing belongs to your COPD patients. And finally, upper airway obstructions prolong inspiration, while lower airway obstructions prolong expiration. To conclude, respiratory rate and breathing patterns are simple bedside observations that can reveal profound insights into respiratory, cardiac, metabolic, and neurological diseases. Before ordering investigations, we should first learn to observe how our patients breathe. As Sir William Osler said, listen to your patient, he is telling you the diagnosis. Thank you.